Welcome to Own Your Heart Health. I'm Dr. Regina Druz, your holistic cardiologist. This week, we will dive into common heart health concerns, uncovering root causes, and unpacking scientific discoveries and controversies. The information provided does not constitute medical advice. Please contact your healthcare practitioner before making any changes that may impact your health. Well, Happy New Year, everybody. It is the beginning of 2026. And for this first episode of 2026, I'm actually flying solo. And the reason why I'm flying solo is that I want us to kind of zoom in on some of the really, really critical topics for health, wellness, and longevity, and to set the tone for the 2026 in general. This is beginning of the year, so Happy New Year to everyone. And I'm sure all of you are making some plans to uplevel your health. Let's call it the January effect. But today I'm going to tell you something super important and something very personal, something that only my family and very close friends know. And the reason why I'm telling you this is because finally, after nearly 2 years of dealing with this issue, I have courage to share my journey, and hopefully my journey will inspire you to make changes. And so here it goes. In December of 2023, I was shopping at the mall, local mall, some holiday gifts for friends, family. And I entered this mall, from my usual entrance. And right to the left of me was an interesting outfit. It was called Pure Mammography. And it was a new sort of medical business concept where you could walk in and have a mammogram, just walk in, just being in a mall, right? You didn't really need a doctor prescription. You could just come in and get a mammogram done. And at that time, I just started myself actually on hormonal therapy, hormonal replacement therapy, something that we do for a lot of our patients. I did not self-prescribe it. I actually went to one of the online prescribers, and they have asked me an important question. They said, when was your last mammogram? And I could not really remember very closely when it was, because as a woman in her 50s who never had any high risk features, any issues specifically on my mammogram, no family history, I didn't consider myself particularly at risk of breast cancer. And you probably understand right now where this story goes, but I'm going to tell you the full story anyhow. So I went into this Pure Mammography place. It was at Roosevelt Field Mall. And I thought, they were new and they were trying to really do the things right. But, I got my screening, I went on, and then I started getting phone calls and letters that there was some sort of a tiny little density in the right side in one of my breasts that perhaps needs a closer evaluation. And I thought to myself, well, this is, a new concept. Maybe their technologist wasn't as experienced. I always had dense, breast tissue, something that a lot of women have. And maybe they're just mistaking, some of these non-specific findings for something that could be more serious. But to make sure that I wasn't missing anything, I actually went to my local healthcare system, St. Francis Hospital, Catholic Health Services, who have an outstanding women's health center. And they have given me a full workup, which consisted of a mammogram and a breast ultrasound. And a very experienced radiologist came back and said, there is something so small that I have a difficult time seeing it, but just to be on the safe side, let's biopsy this. So I will fast forward my story for you. In February, we will be celebrating American Heart Health Months. And in January, and actually in early February, I will be part of the group of doctors who will be releasing a docu-series on cancer so that you could learn a bit more about it. And
the goal of today's episode for me is not only to share my story, but to help you understand that the fundamental root cause processes that are driving heart disease are also driving cancer. And especially in women in menopause or perimenopause, heart disease and breast cancer share such powerful common drivers that we have to know what they are, we have to unpack them, and we have to reverse them. So, my story coming back to this, my biopsy results were positive. I had both ductal carcinoma in situ, known as DCIS, and very early invasive breast cancer. It was called stage 1. I had multiple workups. This tumor was 4 millimeters. It was very common tumor in my age group, estrogen receptor, progesterone receptor positive. And on April 1st of 2024, it was removed from my breast, and I had what's called an abbreviated radiation protocol and was put on tamoxifen. This story plays out for American women hundreds of times. 1 in 8 women in this country will have breast cancer in her lifetime. And I didn't have any genetic predispositions because, being who I am, integrative holistic longevity doctor, of course, I tested my genetics with every single one available protocol, including whole genome and whole exome sequencing, and whatever sequencing was there, I had done. But I had something else, something which was so much more powerful and so much more devastating that it started my journey in trying to unpack these root causes, these fundamental factors that are driving breast cancer and heart disease. So this is why I, as a cardiologist, in this first recording of 2026, I'm going solo because I want you to understand that this is just not about my story. My story ended relatively well, although it's not really the end, it's just the beginning of what I need to do with myself in order to increase my health span and my lifespan. But for many women, that story doesn't have necessarily a good ending. And so I want you to zoom in this year on the factors, critical factors. We're going to talk about 6 factors that are of the utmost critical importance. And the reason why they're of this utmost critical importance is not only because they shape our health trajectory overall, but they shape or give us a certain influence on majority of chronic diseases. And these diseases, non-communicable chronic diseases are usually associated with aging, but I'm not such an old woman. And a lot of women are beginning to show signs of these abnormalities, of these lifestyle factors very early on. And that was my story. And so today, we're going to unpack those 6 critical factors, and I'm going to start a discussion on what you can do to find those factors, figure out how much they may be influencing your health, and bringing these factors under control. So, what are these factors? Now, if you're listening to me on your favorite podcasting platform, thank you so much for listening. I am extraordinarily encouraged by how many people actually listen to my show, even though I'm sort of a brand new podcaster. I do, however, want to give you a chance to see this on YouTube because I wanted to go through a couple of slides, nothing too overwhelming, but sort of just to bring home these points. If you do want to download these slides, I will not be attaching them into the show notes, but I can show you exactly how you will be able to do this. So you can download these slides in a very, very easy way. We have something called Holistic Heart University Community. You can access it by subscribing to our newsletter on the Holistic Heart Center's website. So actually, let me show you this real quick so that you know where you need to go. So here, if you are on the Holistic Heart Center website, you will see a lot of our podcast episodes. Usually our most recent episode is in the front page. When you subscribe to Holistic Heartbeat newsletter, you get invited to be a part of the Holistic Heart University. You won't get a lot of these other features on the site when you are just a free subscriber, but you will get our podcast and you will get our newsletter and you will get a lot of information with that. So when my staff posts the podcast into the Holistic Heart University, we usually include any files that I was providing or shared during the podcast. And sometimes those are not included in the show notes because there just isn't an easy way to do so. So hopefully you will, listen to my plea for you to go ahead and subscribe so that you can also understand or at least get access to the slides if that's what you want. We also have patient handouts or prospective patient handouts that we regularly post in the Holistic Heart University that you can save for yourself. They're usually infographics or short summary notes that you can just use for your own learning. But let me go with you into the presentation that I do want to share because I celebrate two birthdays. One is my regular birthday, and another one is April 1st, which was the day of my lumpectomy. And I'm eternally grateful. Before I go into this other discussion, I'm eternally grateful to my longtime friend, Dr. Zoe Goldberg, who works at Memorial Sloan Kettering Cancer Center, whose swift intervention brought me into the contact with an absolutely amazing breast cancer team, including breast oncologists, radiation specialists, and breast cancer surgeons. I am forever indebted to the utmost remarkable team whose professionalism, expertise, and ability to understand me as an individual was beyond anything that I had ever seen. I thought personally, having created a concierge cardiovascular practice, I provide this level of care to our patients, but I was absolutely overwhelmed by how spectacular Memorial Sloan Cancer team is. And if you ever get a solicitation from Memorial Sloan Kettering or any other national cancer center or even American Cancer Association or American Cancer Society to contribute for research and development, please consider doing so. But today I want to go into the mechanisms because there's been a lot of talk about menopause, and menopause is not just having a moment, as I say, but it's actually having a movement. It's becoming something that is recognized in the workplace, recognized among the experts, recognized among the general public, and certainly women as they're going through menopause. And I want to give you a view that is shaped by my personal story, my story of having breast cancer, even though I thought that would never be something that I would be subjected to, and to really zoom in on what are these shared mechanisms that you must know about, you must evaluate, and you must address because they shape our cancer and our heart disease risk, and also the risk of dementia and risk of aging overall. So let's get into it. The heart disease and the breast cancer are two diseases, and one potentially could say, well, what is the connection? The connection comes from the critical window of perimenopause plus menopause, and it really tells us that there is so little that we know about this stage of life in in all women, all women, if they make it to an age of 40s, 50s, and 60s, will actually go through the menopausal transition. So in the current medical literature, perimenopause, which is about 10-year or so period before menopause, is not actually even recognized as a stage, although we recognize it clinically. The challenge of perimenopause is that the definition isn't really there. There could be many different symptoms and many different signs, but we don't sort of have very strong objective markers. The menopause is still being defined in a very simplistic way. It's defined as a period of life where a woman doesn't have her menstrual period for about a year, right? So it's a very mechanistic way, but it's also very rudimentary. And so we know that there is this overlap in terms of risk that starts in perimenopause and sometimes even earlier and escalates into the menopause and manifests itself post-menopause, the overlap between heart disease and breast cancer. And so this window, approximately 10 years or so before menopause, and of course the menopause and post-menopause, this is the critical period. And the perimenopause is actually a critical window of opportunity both for heart disease and breast cancer prevention. So why is that true? And you could see here on the slide that cardiovascular risk becomes particularly evident approximately 7 years after breast cancer diagnosis, right? So there is, this window isn't short, but if you're a woman in your late 30s or even early 40s, this isn't too early to start thinking, what is my breast cancer risk? And what is my heart disease risk? And while you may be going for regular mammograms, and I absolutely endorse that, having gone through my own experience, you should also be going for regular cardiovascular disease screening. Now, the problem with cardiovascular disease screening is that in essence, it doesn't really exist. We screen for risk factors, and our understanding of risk factors is shaped by population statistics. We are not, if you go into general, let's say, cardiology evaluation or primary care evaluation, it's not really shaped by your own risk factors. It's shaped by what we infer from studying large populations. For example, Framingham Heart Study, multi-ethnic study of atherosclerosis, we identify certain factors that occur in population that sort of rise to the top. And these are called standard modifiable cardiovascular disease risk factors. Sometimes abbreviation people use is called SMRF, so it's interesting, you can either have a SMRF or not. But what is happening here is that the factors, the root causes that are actually driving breast cancer and cardiovascular disease in women are not well represented in standard cardiovascular screenings. Sure, we'll look at lipids, we'll look, cholesterol, obviously. We'll look at sugar control. We'll look at biometrics, body fat composition, visceral fat, very important, smoking, of course, hypertension, sedentary activities. All of these are very reasonable population level risk factors to look at. But women in particular are not only suffering or being exposed to these standard risk factors, but they have other secret drivers that we're going to go into a minute that are actually primarily influencing their disease risk, and not just breast cancer risk, but cardiovascular disease risk as well. So there are 6 of these factors, and my slide seems to be a little off here, so I'll just tell you what they are real quick. Let me just, maybe I could make it a little smaller, because I think it just doesn't want to display itself here. So, I made it a little smaller for you. So what are these 6 pillars? Estrogen. Now, estrogen depletion is commonly recognized. I think it's also important to look at estrogen dominance before depletion occurs, because that sort of like sets the stage. Chronic inflammation, oxidative stress, immune system dysregulation, insulin resistance and metabolic syndrome, and environmental toxins. So these are 6 critical critical mechanistic pillars that link breast cancer and cardiovascular disease. And it's probably not a surprise, but let's unpack what they are, how you can find them, and what you can do about them. Now, the problem here is that we test for some factors, right? We could infer from the lipid panel, for example, if there are signs of insulin resistance. We can sometimes detect systemic signs of insulin resistance by measuring fasting insulin, hemoglobin A1C, and calculating HOMA-IR. But these are sort of, late steps in the process. There is no algorithm that puts together chronic inflammation, oxidative stress, immune system dysregulation, environmental toxins, and somehow spins it around with regard to the hormonal state that could give us a way to understand if a woman in front of us is at high risk of breast cancer and heart disease. And I can tell you that my own labs have been really great, except for inflammatory marker, except for tissue level insulin resistance. And, as a physician, as a cardiologist, because I was trained in a traditional cardiology system and then sort of pivoted to integrative and holistic cardiology, really educating myself and creating a program that helps our patients. My leaning was into the kind of lipid regulation, right, which is very common. And I tended to perhaps overlook other facets. And so we're not going to do that anymore because now, as educated patients and astute physicians, we can understand that the commonly proposed risk estimators for cardiovascular disease and even for breast cancer risk are missing these critical components that are actually shaping both diseases. There is a tremendous overlap among those 6 mechanistic pillars. So what are they? Obviously estrogen depletion is the easiest one to understand. It is both a marker and a root cause, right? Now, estrogen, progesterone, testosterone story in menopause and perimenopause is a complicated one because there are different trajectories of rise and fall. And a lot of women like myself go through estrogen dominance before their estrogen starts to decline. Now, we need estrogen because estrogen promotes endothelial function and nitric oxide dependent vascular health. Specifically, it helps us to keep our blood vessels pliable and dilate. It also exerts very potent anti-inflammatory effects and help us to regulate oxidative stress. So it's a very powerful hormone. But we have a little bit of an estrogen paradox because while it's protective for the heart, it could also influence breast cancer cells. And so I asked my oncologist, because at the time of my diagnosis, I was on HRT. Of course, I stopped it immediately. Mine was at low doses. And she said, it is highly unlikely that it had an impact or that, you ended up with breast cancer because of HRT, because your time of exposure was fairly short, and breast cancer lives inside the body for at least a decade in this, ductal stage before it even tries or before potentially it spreads out or becomes invasive. And what I can tell you is that at the biopsy diagnosis, my tumor was 4 millimeters. I subsequently put myself on the same regimen I put a lot of my patients, and approximately 8 weeks later at the lumpectomy diagnosis, this tumor was only 2 millimeters. It shrunk by 50%. Now, this is not uncommon, and we can certainly talk about what this potential regimen might be. If you're interested in this potential regimen, we do have a notebook LM that potentially could give you some ideas. It's called, Heart and Diet or Heart and Supplements. So when you become part of the Holistic Heart University in our Heartwell Launchpad, you get access to all of these resources, and we have regular meetings with our patients. So, our open office hours with the members of the Holistic Heart University and with our patients, where we discuss a lot of these strategies, right? But here I want you to understand that While the timing of hormone therapy is critical, and we have studies that show that early initiation may provide cardiovascular benefit, and we also now have a revision of how we think about hormonal therapy. And I actually wrote about this in my most one of my newsletters. If you look at the Holistic Heartbeat newsletter from November, and the link for the newsletter is always in the show notes. So you don't need to go hunting for it. You can just click on it and you'll see all of my editions. This newsletter comes out once a month. So, there aren't that many of them because I started it recently. But what I'm trying to tell you is that the hormonal therapy thinking had evolved, right? There has been a removal of black box warning, and we have recognized that hormonal therapy can be quite beneficial for women, and that it's time for us to personalize what we do with the hormones. But assessment has to be very, very careful. Any woman who thinks that she's going to jump onto hormonal therapy bandwagon and magically all the other issues that are driving or arising during premenopause and menopause, such as chronic inflammation, oxidative stress, immune system dysfunction, insulin resistance, that somehow these things will all be addressed by hormonal prescription. This is unfortunately not the case. I wish it were the case, but it isn't the case because a lot of these changes are cellular changes. They're deeply physiologic and they require a multi-pronged approach. But estrogen depletion or estrogen dominance are both relevant for breast cancer and cardiovascular disease. There isn't a simple story to be told, but the story is much simpler for other factors. So, what is pillar number two? Pillar number two is chronic inflammation, right? Inflammaging, which is the aging of our organs due to inflammation. This is a silent fire that burns in the body, not only in our blood vessels, but also in the tissues that potentially could be sensitive to cancer cells, right? And with estrogen, when the estrogen starts to drop, or when you have estrogen sort of spiking and dropping, perimenopause and menopause sort of marks this transition to what essentially is a chronic state of inflammation, right? It is rare in my practice for me to meet a woman, no matter how great her lifestyle effort is, who has not sustained an increase in at least one inflammatory marker as she transitions into the menopausal state. I had seen it happen to me, and I had seen it happen to countless women where their high sensitivity C-reactive protein, one of these super common markers, actually rises with menopause, and it could rise to substantial numbers. There's at least 20-30% increase with menopause, and in different individuals, these numbers could be significantly higher, and it reflects multiple inputs and actually most likely reflects activation of the immune system as well. And so when estrogen goes down, it removes that key anti-inflammatory brake that used to keep the inflammatory markers in check. And for some individuals, both men and women, there are actually genetic predispositions where they tend to have a higher predisposition toward inflammation at baseline. So menopause is a transition that is marked by chronic inflammation. And when you position it like this, you begin to understand that's why we have increased risk of not just vascular disease, but breast cancer as well. But if we do target inflammation, we find it, we target it, we will understand, or we will lower our exposure, and we will eliminate or at least reduce the impact of this tremendously important force. Now, inflammation comes as part of a package. You cannot have inflammation and nothing else is happening and the body is just happy, right? Inflammation and oxidative stress travel together, and so is the immune system activation, which we're going to go to in a moment. Oxidative stress is a double-edged sword. Now, we have to have oxidative stress. So oxidative stress simply means that we're producing free radicals. They're known as ROS, reactive oxygen species. Sometimes we can also get them from nitrogen, so reactive nitrogen species. But the point is that these free radicals play a huge role because they actually kill cancer cells. They kill bacteria. They kill viruses, right? So the body is very smart. It knows that it needs to send in first responders, and immune cells are typically the first responders to invaders, whether it's a cancer cell, a bacteria, virus, coronary plaque that is occurring because of the injury to the endothelium. The body sends in immune cells. Let's think of them as firefighters, right? Or containment crew. And these firefighters and containment crew are deploying oxidative stress, right? The free radicals get generated as part of these biochemical reactions, and oxidative stress or free radicals attack the invaders, and they start the process of repair, right? They have to clean up so that repair can start. And the problem is that too much of that, of a good thing, is really not good, right? This is where the paradox is, because we need to have free radicals, we need to clean out cellular debris, we need to kill zombie cells, we need to kill cancer cells. But if we let these free radicals hang around too long, the things go just the opposite, right? So they end up causing more problems than solutions. They end up damaging our DNA, damaging our RNA, damaging our lipids, damaging our proteins. So we have to sort of find, when it comes to oxidative stress, we have to find what I call a Goldilocks solution, right? It has to be just right to protect you and not to cause harm, right? And if you think about it, oxidative stress, you encounter it in daily life. Every time you exercise, there's oxidative stress. Every time you fast, there is a certain amount of oxidative stress. So we need to balance the beneficial impact of oxidative stress with its increased risk. Now, I already alluded to the immune system, and inflammation, oxidative stress, and immune system. What they're doing is that they're forming this very powerful Bermuda Triangle, right? When I was young, I grew up in the former Soviet Union. We didn't really have a lot of information or access to, different things. And so I loved to follow these stories that, Russian press, usually being very political, occasionally would sort of depart from the political conversation. And it would put some interesting stories, some sci-fi stuff or some science discoveries. To make a long story short, I really loved the stories that were about Bermuda Triangle and disappearance of aircraft and ships. It was tantalizing and it was very mysterious. But now, as an integrative and longevity doctor, I can tell you that one can truly disappear inside a biochemical or biological Bermuda Triangle, and the sort of three angles of that Bermuda Triangle are inflammation, oxidative stress, and immune system imbalance. And these are core issues. They are core issues driving cardiovascular disease. They're core issues driving cancer, because especially the immune system, when it gradually deteriorates, and this is again starts in perimenopause and sort of goes off the cliff in menopause, the body shifts into the state where it's unable to clear out the things that need to be stabilized. So we get plaque instability, we get increased propensity to thrombosis, which is blood clotting, we get impaired surveillance of cancer cells, right? Allowing cancer to start its invasive process, right? So that's the bad news. The good news is that we can measure these processes, and we have very strong ways to figure out how to address them. All the biomarkers that you see here, except for some in this blue box, but a lot of them are commercially available. They're available from standard blood tests. And if you listen to my episodes before, you know that we use something called Hartwell Toolkits, where we can actually provide a curated collection of blood, urine, and saliva tests. They are not necessarily from a single laboratory vendor. The reason why it's a collection is because each tool in that Hartwell toolkit serves its function, right? We want to map out comprehensively a specific area to discover these pillars, to map out and say, well, this is what's going on here in terms of inflammation, oxidative stress, immune system activation. This is what the markers are. We now have the objective measurement, and we now can work through lifestyle modification, medications, peptides, supplements to rebalance the system and save you or lift you out of that Bermuda Triangle. And we have recently partnered with a company out of Stanford that allows us to include immune system inflammation aging test into one of our Hartwell toolkits. Currently, it's included in Longevity Hartwell toolkit. So certainly this is something that you can get access to and not guess, but test. Now, probably the most impactful symptom or sign of that things are off, and that was my story, because I found myself somehow after in my late 40s, early 50s, probably somewhere, actually maybe somewhat later than that, maybe around the age of 55 or so, maybe slightly earlier, I became aware that my body was changing. I was never overweight my entire life. I tend to be lean. I am an exerciser, but I'm really not an athletic type of an exerciser who does, who goes to CrossFit, but I would go to the gym. But what I found is that my body was changing, and it was changing very fast. It really didn't matter, my diet or my exercise. While previously in my late 40s, and I had 3 children, so of course my body would change, with each pregnancy, with childbirth. So in my late 40s, it was fairly easy for me to normalize my weight. I didn't really have to jump through hoops. But as I transitioned into my 50s, the process became nearly impossible. And this is the story shared by many women. If you are a woman who is listening to this and you have lived through this, or you're living through this right now, please reach out. We have multiple resources to help you. Some of them are the Holistic Cardio University. As I mentioned already, we have Hartwell toolkits that are focused on heart and brain, hormone and weight and longevity. We can solve this problem for you. We have a very specific cardiometabolic program that helps our patients, especially women, to lose the toxic fat from their bodies while preserving their muscle mass. And so I cannot emphasize enough how impactful insulin resistance and metabolic syndrome is. And you could see it from here, is that the risk of disease nearly doubles, right? And we know that this is that perfect storm situation that lands you inside the Bermuda Triangle, because once insulin resistance sets in, and it initially starts on the organ level, you have your liver, you have your muscle, you have your fat, and then potentially spills out into the systemic circulation. One also starts to accrue so-called visceral fat or visceral adipose tissue, as well as turn the tissue around the heart vessels, into a toxic depot, right? So we call this pericardial adipose tissue, or epicardial adipose tissue, or ectopic adipose tissue. I like to call it ectopic adipose tissue because this is sort of in places where it doesn't belong. It's not always epicardial. Sometimes it's around the coronary vessels. It could be also around left atrial appendage, which is the upper chamber of the heart that pretty much is involved with onset of atrial fibrillation. Another heart disease entity that tends to escalate in women with menopause, right? So this ectopic adipose tissue or epicardial adipose tissue, EAT, is really what literally eats your heart, right? And this is absolutely crazy, but I've been looking into this, and there's been multiple publications in cardiology literature that are describing this EAT entity as an invasive entity. When you see it here on this little slide, this pericardial fat or epicardial fat, it is actually capable when it's epicardial. Epi means right on top of the cardium, which is our heart. It actually sends fat cells inside the heart muscle tissue. And it makes a woman in menopause, a lot of women in menopause over time, especially after menopause, have stiff hearts, right? And they may have shortness of breath. They may have palpitations. They may have noticed that their exercise tolerance had reduced. Now, they don't have coronary disease, right? It's not the blockages in the coronary arteries. It's a structural heart problem. This heart becomes stiff. And it could go all the way into the entity that we recognize as heart failure with preserved ejection fraction, or HFpEF. It's a technical term, but basically what in human language, it means that the heart just is too stiff. So it cannot really stretch when it fills out with blood. As a result, when it pushes the blood out, it pushes out a smaller amount. It's not enough to meet individuals' needs. And so one ends up with this syndrome or symptom complex. And I actually call, the insulin resistance, the inflammation, the oxidative stress, and the measurable signs of menopausal heart a menopausal heart syndrome, right? And we'll do a separate episode on the menopausal heart syndrome so that you'll understand exactly are you even, having any signs or symptoms? But, luckily we can measure a lot of this. We can measure the heart thickness. We can measure the heart stretchiness. We can measure how stiff your arteries are. These are all in-office measurements. They're not particularly difficult. And there's something that could change fairly quickly within 3 to 6 months. So, they provide both an objective measurement of your baseline as well as an opportunity for improvement. And this is why in 2026, we invite all of our patients, and our patients get it once or twice a year, but all of our new patients, we're offering them cardiovascular longevity assessments, which actually will give you this information. They will give you an estimate of your vascular age. They will give you an understanding how stiff your arteries are. And we are rapidly approaching the era where we will be able to quantify this fat, EAT fat, epicardial or ectopic adipose tissue around some of the important heart structures. This technology is already there. There's technology right now that not only measures this fat, but measures the degree of inflammation in this fat. And so it's in use in Europe, and it's coming to the United States. So keep an eye for our announcements when this technology will become available to us. But insulin resistance and metabolic syndrome, we can fix it, and this is such an important driver that it needs to be addressed in every woman. And that was my problem. One of my problems is that looking at my blood work from the period that preceded my diagnosis by a bunch of years, I could see this progression toward insulin resistance. Diabetes runs in my family. So while I was never pre-diabetic or diabetic, some of the patterns in my blood work provided a clue. And if you listen to my episodes before, you know that some of these patterns, you don't have to have any fancy testing. You can understand these patterns from fairly routine laboratory panels. You need, of course, your fasting lipid panel, because we will be looking at the ratio of triglycerides to HDL cholesterol. Any ratio that is 2 or greater is typically highly correlated with insulin resistance. And of course, I already mentioned this, high sensitivity C-reactive protein, easily available in all standard laboratory panels. So if you need the basic of the blood work, you should be able to get at least a standard lipid panel in a fasting state and high sensitivity C-reactive protein. Of course, there are additional cardiometabolic and cardiovascular markers that play a tremendous role and allow us to personalize our intervention. But for the purposes of understanding if you're insulin resistant and inflamed, you don't need many markers. You just need, key markers to be available. What I also learned in my own journey, in my own process, and working with our patients is that one cannot underestimate the impact of environmental toxins. And yours truly here, I call myself a detox disaster because having gone into a pretty in depth evaluation after my diagnosis, I discovered that my detoxification pathways, mitochondrial and cellular pathways, genetically have not been aligned with the best scenario, right? And so some of the exposures that I had in the course of daily life were, of course, not assisted by my genetics. And, I did not really had a plan in place to alleviate my genetic burden so that I can deal better with the environment. And, a big role right now, a big conversation is shaping up about environmental toxins, about endocrine disrupting chemicals, which are critical because no standard cardiovascular equation will measure this, right? You have to measure this directly. And unfortunately, as women, we are prone to accumulating this because we tend to have higher adipose tissue content than men. And as we're gaining this visceral fat, this ectopic or epicardial fat, or EAT, as I call it, and that's actually an official abbreviation, during perimenopause and then into menopause, we basically begin to not just sustain inflammation, oxidative stress, deregulate our immune system and develop insulin resistance metabolic syndrome, but we add the toxins on top of it, right? And this is what literally, in my mind, since I'm somebody who did not have standard breast cancer risk factors, this was the critical factor. It was insulin resistance, chronic inflammation, and environmental toxic exposure. And by toxins, I don't only mean environmental, although this is something that we're testing for, but you could also have a toxic situation at work. You could also have a toxic situation, in a relationship, a highly stressful situation, and that would feed into this whole, Bermuda Triangle setup, right? So this is the bad news. Now, the good news is that, again, this is testable. And, part of our longevity toolkit is what we do. We test for this in addition to the oxidative stress, because these are such impactful, critical variables that are actually connecting breast cancer risk and heart disease risk, not only coronary artery disease risk, but all heart disease risk categories that in women especially seem to have a very strong biochemical component, right? And this is absolutely is something for us to unravel. So the critical window of opportunity is there. Any woman, as I said before, in her early 40s and especially in her early 50s, or, should always understand what is her vascular risk. I know many women go for annual mammograms, breast ultrasounds, maybe breast MRIs. This is super, super important, but you're not doing a complete job of understanding what your risk is of breast cancer and heart disease if you're not looking for these 6 pillars, if you're not measuring inflammation, if you're not measuring immune system activation, if you're not measuring oxidative stress, if you're not measuring your toxic exposures, if you're not aware if you have insulin resistance or not. And, here is an important sort of pearl: just measuring your hemoglobin A1C does not tell us much about your insulin resistance, because, as I said early on, it's really organ and tissue based, and hemoglobin A1C measure is primarily standardized for diabetic patients and, controlling their diabetes with medications. It's much less standardized for patients who are looking to detect early signs of insulin resistance, right? So these are the measures that need to happen. These measures very often are independent of chronological age. But if you take your blood work, maybe you had it, for a few years or here and there, and you sort of start, go and take it, go and see a pattern. If you measured your high sensitivity C-reactive protein and you see that over the years, it may have been below the risk cutoff, but maybe it had doubled. Well, that's the move in the wrong direction, right? Now, we do have that window of opportunity is not necessarily very short. It's actually quite significant. It's about, 10 years or so. When that window starts is difficult to say. If one is looking for hormonal replacement therapy, then typically we advise for women to start it within 10 years of menopause, or if they're younger than the age of 60. But we know that their risk is sort of compounds and it continues to increase after these substantial diagnoses, like breast cancer diagnosis, for example. Cardiovascular risk accelerates and becomes clinically evident within plus minus 7-year time, right? So early intervention is critical because early intervention is the opportunity to break free of this Bermuda Triangle. Because as the body begins the transition, if you don't have a solid program in place to allow you to do it while mitigating the impact of these 6 critical pillars on your body, then by the time that transition is in full swing, the interventions are not as effective and some of them actually carry a risk. And this is why it's so critical to understand this. Now, the good thing is that we are experiencing a paradigm shift, right? We are right now in the era where people are more open and even practitioners are more open to understanding a more integrative point of view, right? A point of view that goes away or goes beyond cardiovascular risk factors to really identifying these pillars, these root cause drivers. And we have multiple tests, most of them easily available, that can measure all of these things that we're discussing. For example, in our hormone and metabolism Heart Toolkit, we measure full hormonal profile, oxidative stress, endocrine disruptors, so that, and also your nutrient, and micronutrients, so that you can have a full picture that will allow you to get started with your risk factor, your personal risk factor modification, not just population risk factor modification. So there are ways to do this. You can get it with a simple blood panels. You can get it with things which are a bit more involved, like Heart Toolkits, but it is absolutely possible to do this. Now, I don't want to go into the strategies yet because this will require a kind of a broader discussion. What I do want to say is that lifestyle is key. And by lifestyle, I don't just mean Mediterranean or DASH pattern, but a structured program that brings together foundational and interventional nutritional approaches like fasting mimicking diet, for example, a specific exercise prescription, weight management. And weight management, of course, had gone way beyond just sort of conservative things or even using metformin, but obviously with incretin therapies, GLPs and GIPs, and pretty soon triple incretin therapies, medications like Wegovy, Ozempic, Mounjaro, Zepbound. There is a tremendous opportunity not only for weight loss, but for metabolic remodeling. And look for the upcoming issue of the Holistic Heartbeat newsletter and for an episode on this podcast that will be coming out in February, where we're going to talk about metabolic disease modifying drugs, right? MDs or MD2s. These are the drugs that you hear about on TV regularly, right? You hear about these, the Ozempic, the Wegovy, Manjaro, Zepbound. At the holistic heart centers, we have a very specific program. We actually use some of these medications in the off-label fashion by figuring out a specific dose that is going to have an anti-inflammatory and immune stabilizing and weight loss benefits, as well as vascular benefits for our patients. And so these are microdosing protocols. Microdosing protocols are an emerging area of using these medications. GLPs and GIPs and triple agonists are peptides. There's a lot of talk about peptides, but these are pharmacological peptides, and they are very powerful. And if you are a woman getting hormonal replacement therapy, you should know that these peptides, these incretins, actually work synergistically with hormones. I'm not a big fan of statin drugs. I use them when I have to, but statins and also Repatha, which is not a statin, but this is so-called PCSK9 inhibitor, have been shown to have anti-cancer properties as well as metformin. So we're going to have a lot of discussions on these, because you could obviously tell that I'm passionate about this because of my personal story, and also because of the things that I do with my patients. I want my patients and I want myself to be on the longevity path that is going to give them the highest return on investment. Not just do the supplement or do that exercise, but really to bring data-driven decisions so that patients can understand where they're likely to make the most improvement. And so that starts with identifying the mechanisms, right? And so hopefully this presentation here convinced you that breast cancer and heart disease are driven by 6 very strong shared pillars: estrogen fluctuations, including estrogen depletion, inflammation, oxidative stress, immune dysregulation, metabolic syndrome, and toxins. And we have great ways of beginning to figure it out. It is not experimental anymore. It should be a routine part of every practice. We have that critical window of opportunity, that menopausal transition, and 10 years prior to that. And, and none of us know when we're going to fully transition into menopause, but, you can ask your mom, when did she have her menopause, and maybe start working on yourself 10 years before that timeline, so that you begin to understand. I am a firm believer that the sooner the better. I have 3 children. 2 of them are women, my daughters, and they're in their 20s, and they are already following, a protocol, a lifestyle protocol that hopefully will serve them well into the future to prevent both heart disease and breast cancer. Metabolic urgency is critical. We as women transitioning into menopause have metabolic disease factors, right? Metabolic syndrome, whether it's classically diagnosed or peripheral insulin resistance, we are escalating this, our bodies are escalating this with menopause, right? So metabolic urgency has to start early. And, demand that level of screening from your primary care doctors. As I mentioned before, these are simple blood tests. They're not very complicated. And certainly things like following your biometrics. For our patients, for example, we routinely use body composition scales that they step on these scales at home, and we could see what is the percent body fat, how much visceral fat they have. This is an objective marker that we can reduce. And so this is time right now for unified prevention. If you're a woman listening to this, whether you're an older woman, younger woman, I want you to understand, or a man who cares about women in his life, there is an opportunity for unified prevention, which is powerful. And it's powerful because it addresses some of the factors which are fundamental factors. And I want you to understand that you don't need to do anything too extraordinary in order to begin this journey. You can begin this journey by educating yourself. You can begin this journey by getting appropriate testing done. You can begin this journey by monitoring your body composition, because instead of just shooting in the dark and embracing this protocol or that protocol or this exercise or this diet, strive to get objective measurements so that you understand where your risk comes from. My risk didn't come from traditional exposures. There was no breast cancer history. There is no breast cancer genetics. My risk came from chronic inflammation, insulin resistance, and high oxidative stress. And I discovered in that process that my immune system was, even though my immune age test is very good, I could stand some improvement. And certainly I discovered that, as I mentioned before, that detox is a big part of what needs to be done. And this isn't a detox where you just, drink juice, for 7 days. I'm talking about cellular detox that influences so-called hallmarks of aging. And there's a whole research out there with regard to hallmarks of aging that will go into during 2026 so that you can understand what they are and you can understand why I advise you, or at least talk to you about certain things that have been scientifically proven to impact hallmarks of aging, because this is a real opportunity. Now, there is a lot of talk about blue zones and, should you live in a blue zone? Maybe you should visit a blue zone, but you can create your own house blue zone if you only understand how. So I encourage you to look at our Holistic Heart University, explore our Heart Health Toolkits, schedule a consult with us, whatever it is that you think may help you. Listen to this podcast, look at the presentation on YouTube, or as I said before, when the episode launches, it will be available on Holistic Heart University. You can download the slides if you want to. And so use it to educate yourself, because education is power. And for all of the women out there who have survived and thrived with breast cancer, please know that I'm one of you. I hear you and I hear myself. And you could see that I'm getting emotional. I didn't plan on being emotional, but this is what it is. On April 1st, I will celebrate my 2-year anniversary. 2-year anniversary. This is what happens when you get emotional. I will celebrate my 2-year anniversary of being breast cancer free. And I intend to stay breast cancer free. And I intend to become as metabolically healthy as possible, which is what I wish to all of you, whether you're a man or a woman, for 2026 and beyond. And I will see you in the next episode.
Thank you for tuning in to Own Your Heart Health with Dr. Regina Druz. This podcast is powered by Holistic Heart Centers. If you enjoy the show, please rate and review us on your favorite podcast platform. To learn more about our services, visit holisticheartcenters.com and subscribe to our YouTube channel. The link is in the show notes. See you next week.